Oh, Dr. Brophy's joining. He's our 25th. That's like the perfect little screen. Excellent. And beyond. I love it. Okay, welcome everybody. Thank you for joining us on an evening meeting when I'm sure you all would rather be just unwinding from your day, but we're going to try to keep this moving along. We're going to cover a bunch of different material. Like I said at the beginning, I want to be sure that there's time for you all to ask questions and have some dialogue in this space too. So I am going to show some slides for certain parts of this as we go along, but I'm trying not to screen share too much, so that for those of you who want to show your face, hello Joanne, thank you for doing that. You feel free to do so. If you don't want to show your face, you do not have to, but feel free to unmute and speak. What our agenda for tonight covers a lot of things. We're going to start off just very briefly. I wanted to give you all a sense of where we are right now in terms of our 2020 quality metric performance, because our quality metrics for peds are all the things you do every day. It's well care visits and immunizations and blood testing. And so the story is pretty remarkable in a pandemic. That's what I would just say. And that's why I'm not showing screen or going through all the numbers. Suffice it to say, I've said it before, but I think everybody has done a remarkable job in terms of prioritizing getting the kids in who needed to be seen most acutely, keeping up in terms of immunizations for our youngest kids in particular, and then tried to do a lot of catch up for the school age and older kids in the summer and early fall, and in the midst of all the other incredible amount of testing and assessment that you all have been doing. So we're actually, if you look at our product lines, we look at the Excelis performance, because that really is kind of where we get a lot of our baseline stuff from, since it's the majority of our patients in the commercial contracts. We're really knocking it out of the park at the 90th percentile or above for all of the pediatric parameters. And so again, in a pandemic year, that's kind of amazing. The only one where we struggle in right now is well child visits 3 to 6. And I think that's also in part a reflection of the pandemic, because those weren't our highest prioritized kids early on. I know you all have been working hard to catch up on them. I would just, as you can, continue to look at your numbers in those areas, look at those patients and trying to get them in. But again, a really nice job. And actually in the Medicaid space, to me just points out the disparities that we know exist, that we continue to struggle with a lower benchmark and still not able to reach those patients to the same degree. But again, I would highlight that we're actually doing better than last year in the Medicaid space in terms of childhood immunizations and in terms of childhood-led screening. So that's progress in a pandemic, and that's pretty darn good. We have a ways to go when you look at things like the well care visits for the 3 to 6 year olds and for the adolescents. And I think we all know that, and there are many barriers to those visits. But I think we will just continue to work with you around that as we go into this next year. I don't know what we're going to be up against, if we're going to need to do reprioritization again around our well care visits like we did before. Part of me thinks maybe not, because part of the reason we had to do that was while everybody figured out their processes for seeing patients safely. But it's one of the questions I would pose to you guys to think about, and we kind of have open dialogue. Please let us know from AHP and how you're doing in your practice. But overall, really, really good performance in what has been just an unbelievable year. The one thing I would ask everybody to think about is Adolescent Combo 2 vaccine as we move into next year. If you remember, that was a priority for us this year. This was our transition year to kind of put processes in place so that we could more readily meet that metric. And so I know a lot of you who may have given that vaccine at different times were adjusting that. I would ask, it would be a great time this month, take a look at your numbers and your rates on Adolescent Combo 2 to see how you're doing. Again, remember, the metric we're up against, the benchmark we're up against, is in the 30% range. It's not in the 90% range, but we still are not quite making that metric in the Medicaid space. So if everybody can kind of look at your processes and make sure they're aligned now, we will continue to work with you into next year. So that's kind of where we are right now in terms of metric performance. But really, I think it's really how we're doing for our kids and for their families in terms of the high priority things we need to be doing in preventive care. So nice work. From there, I just wanted to move into talking about all of the testing stuff. And many of you joined the 12:15 call today where Chad went into a lot of good detail around that. So I don't want to repeat the same things. I actually wanted to speak very quickly about the changes that came from the governor this week in terms of the testing in schools. And then I actually just wanted to open it for questions if people have questions about stuff and go back and forth a little bit on that. So the big difference, and a huge shout out to, I think Dr. Brophy is on here, to Dr. Brophy and the leadership from Adolescent Children's, to people on this call who are on the schools reopening task force, to our county health department leadership, and our school leadership. There was a tremendous amount of advocacy and outreach to the governor and to leadership at the state to ask for them to please reconsider what were honestly impossible guidelines to be able to keep schools open as our communities went into higher and higher rates of prevalence. And I think you all know, we've talked about this, it's very clear that it's not the schools that are the source of spread. Their schools have done a really nice job with that. And it felt like not the appropriate thing to shut down schools and bars at exactly the same time. And so we got dealt a new hand. Or as I said to somebody, wow, we just bounced to a different Jumanji level. This one's better. And so, as I'm sure you're aware, all of the guidance has changed now. And so for our communities that are in an orange zone, no longer do the schools have to test 100% of kids in order to come back. They actually can stay open, but have to commit to testing 20% of all students and staff who are in person. And that's over the course of a month. That's not 20% a week. That's 20% over the course of a month. So really, when you think about that, 5% of students and staff per week will need testing. There's a little confusion about that. I did confirm that with our county health department to make sure I wasn't misinterpreting what I was reading in the guidance, but that is actually true. If a community falls into the red zone, then the testing requirement, the asymptomatic testing requirement at school goes up to 30%, but again, for over a month. So that is like night and day from what it was. It doesn't change any of the other guidance that has been out there yet. It doesn't change anything about that the antigen testing that's being used currently really is not testing that we want to be using as a frontline for symptomatic patients. We still preserve the gold standard in our community that PCR testing is better for symptomatic patients. I keep watching this with all of you too, as our prevalence rates rise. At what point does that story change? We haven't gotten there yet. Nobody has given me exactly what number that is. So, and I know that all of you have heard, as Chad has done a really nice job with Renee in trying to look for potential opportunities to help support rapid PCR testing in practices through either the Rochester or probably less likely through the Cepheid Express platform, just because of the concerns about reagent. But I wasn't going to go into a lot of detail on that either. If people do have specific questions, I'm going to just say Chad has become the expert on this. He is the person who is doing the go-between with the Roche-Liat folks. But I just wanted to stop right there and just say, what are your questions in this space right now, specifically around testing? Or if you have questions about the assessments that you're all doing for symptomatic kids and attestation for school. So Toby is asking a question. Can you bring me up to speed on the tests, which is most reliable and accurate? So PCR testing always is most reliable and most accurate, Toby. But it turns out that in addition to the PCR testing platforms that are being run out of the labs locally, Cepheid and Roche each have a platform that's rapid testing. And that is something that can be done out of a pediatric practice or a family medicine practice, for example. You need to have a significant volume of patients though. So I personally don't think these would be a great option for independent or for smaller, 1 or 2 person practices. But if you have a larger practice or you're seeing a large volume, or certainly we know that the independent urgent care's acute kids already has a platform that they're utilizing. And I know that the parent and urgent care, pediatric urgent care is also in line to get set up for one of those too. You need enough volume. So when they say rapid just means fast. So rapid testing in the PCR space, I mean, that sounded kind of stupid, sorry about that. But rapid does mean fast. The turnaround time is like 30 minutes or whatever. It's something that you can get back. It's not waiting for multiple days on end. And those are, their accuracy, their sensitivity and specificity is very good. When people talk about rapid tests in general, most of the time they're talking about antigen testing. That's the tests that are the self-administered ones. Those are the ones that are being used in the school. Those are the ones that are being used at like your local Walgreens or CVS or places like that. Renee, you gotta help me with the questions because I am trying to.
You've got one that's, we're looking for some information on reporting guidelines to Department of Health.
Can you, whoever that was, can you elaborate your question?
Yes,
What about
it's me, Jen Lessick. How are you?
Hi, Jen. Oh, good. Thanks.
We have the Cepheid in our office and it's working wonderfully.
Awesome.
It's taking about 45 minutes. Our issue is that we need to report both positive and negative to the Department of Health within 24 hours.
Yes.
And the negative for each cartridge requires 3 reportings, obviously, flu A, flu B, and COVID for the negative, and it is taking a tremendous amount of time for that reporting guideline. So I just wanted to put that out there.
Well, I'm glad that you mentioned it because it is one of the downsides. And that's true if you're doing, the schools are needing to do the same thing, but they're not doing flu and COVID and RSV or that. So for the number of you who have the Cepheid platform, because I think English Road just posted that they have that too. Are you guys doing okay with getting your reagent? That's a big question of a lot of other practices that are trying to decide which they might go with.
Our allocation has been really good.
Awesome. English Road? I think I saw Teresa in the chat. Do you mind unmuting, Teresa? How are you guys doing?
Teresa mentioned that they have Cepheid at English Road. PCR takes about 35 minutes. Yes, we've had for a year, no problems.
Okay.
And Liz from Genesis, what is the stance regarding children who do not have a consent on file for testing or decline to be tested?
Consent on file in your office for testing, meaning they're there without a parent? Liz, unmute yourself. Ask me that question. I don't know what that question means. If you don't mind, I'm putting you on the spot. Are you talking about don't have a consent on file at school, or are you talking about in your practice?
I am talking about in school. Sorry about that.
No, don't worry. I'm sorry.
At least where our kids go to school in Irondequoit, they're asking everyone to have a consent on file for their child to be tested at any time.
Yes.
So does a child, if they're in a situation where the parents are going to say no to the testing, they haven't signed a consent, do you wait until that child comes up in the random 20%? And then if they refuse, you send them home? Or because I think parents are going to have this question.
I got the answer to this one. I'm so excited because these questions make me extraordinarily anxious. I just want to tell you, I sit here thinking oh my God, please don't ask me one I don't know. But I promise I'm just going to tell you I don't know, and we'll figure it out later. That one I know. So if a parent says no, then they say no, that child continues to attend school and they don't come up in the random sampling, like their name is pulled out from it. There's a recognition that this was one of the big worries about how in the world were we ever going to test 100% of kids, because 100% of parents would never consent. But in all school districts, consent is required. The schools decided to take that stance all across the board. It's not, they didn't want to do just your, opt out kind of thing. This is opt in. And no child should be restricted from school if their parent has said they cannot test them. Does that help? Okay. I saw another question pop in the chat. We'll take a couple more.
More comments, I think, than questions,
Okay.
LJ.
Okay. Yeah, I hear this. The eclairs reporting thing is, so maybe that's the next level of advocacy. Honestly, it felt more important to get them to change the rules about the kids being, something reasonable so kids could stay in school. I can certainly raise this question to the schools reopening task force group. And I actually know that our county health department has been advocating to try to have it be positive reporting only, but I'll bring that up again. I mean, the one thing I will say is the rules haven't been pretty, but we have gotten some changes, so we can work on that one. Doug Bennett, you're allocated 90 tests per month and continue asking me which we typically get. So that's cool. You can run an eclairs report that can be uploaded through MedEnt. Are other practices who are they using that function? I love this when you're sharing like best practices. And the Cepheid will not meet all your testing needs. I see that. Okay. I don't know what else to say with that, but folks, look at Doug's comment in there. And if you want to ask him more questions, yeah, Doug, how do you do that? There we go. Now the questions are going. Doug, I'm going to let you answer that. And I'm looking at Aaron Owen's question here. A recent interaction with Monroe County Health Department had them telling our nursing staff we should be going through an online platform to report positive COVID tests. Prior communication was to email, which is correct. You know what the online platform they're talking about, Aaron? They're talking about if you do testing in your office on one of these platforms and you have to be reporting to the state, that's what they're talking about. They want, everybody has to report on eclairs. There's no exception to that. However, if you have a positive test, there is an email that you can send to the county because the eclairs goes up, throughout the whole Department of Health up to the state. You can report that to the county in the hopes that they can get on that contact tracing even faster. But honestly, with the rates we've got right now, this is one of the things I want to talk about with everybody tonight. I think we need to be, we're going to talk about this on Friday at the schools reopening task force. There has to be better communication in terms of public service messaging. And some of you have talked about this in emails to me and in other conversations, that if someone tests positive, they are in isolation, and people need to understand what that is so that that happens without the county having to come and put them in isolation, right? Because there's this whole idea of what is isolation, what is quarantine. And I think we have to communicate that too as much as we can. I mean, and I don't know if you have suggestions about how to do that, but on quarantine, we have to make it clear. We talked about this at today's Wednesday, or at today's 12:15 meeting. We have to make it clear to people that you don't test out of quarantine. The whole thing about testing out of quarantine for travel was different and extraordinarily confusing. And I think it kind of has messed with people's minds that they think now they can test out of quarantine if they were a close contact. There's no test. And people should not be running around just, trying to get tested if they're in quarantine and they have no symptoms. It doesn't make any sense to do so. It's not going to change their quarantine. So it is okay. I mean, I think we all kind of understand this now. So if you have parents or patients who are asking you, it is fine to say the health department will get to you, but it will not be immediate. And this is what you need to do. You're kind of like, I will say we are all officially deputized, that we could give those pieces of information. More complicated things we need to raise to them. But any other questions that were in there? Renee, you are awesome. Look at you. And everybody emailed Doug Bennett. That's what Doug was saying. Everybody email him who has a question about the reporting function. Doug, can you just copy me on your response so that if other questions come up, and copy me and Renee on that, because that way we can share that with other people if those questions come up. Thank you so much. All right. Any other questions on testing? How is the communication going with schools? Are we doing a little better in terms of, it was a little back and forth for a while there around symptoms and release back to school. Do you think we're doing better? In terms of if you have alternate diagnoses, are we doing better? I'm looking for the few people. I'm looking for, time is running out. Thank you, Renee. Renee's the time holder for me because I didn't want to have to be looking at my clock all the time. All right, better. Thank you, Erin. Okay, I'm going to take that as everybody. All right. This is really funny. I feel like I'm talking to myself, but I know you're there. Oh my God. All my imaginary friends, you're all there for me. All right, Renee, what's the next topic? You got to remind me what I'm on to next.
Your next topic is revisions to the return to play algorithm and the sample release form for group review.
Oh yeah, now this is where you're going to have to unmute and talk because I'm pulling you all in to this question. So this is where I'm going to share my screen for a minute. Try to share my screen. Did it work? Woo-hoo. Okay, let me just get that. Go away. Okay. Okay, so this is where a few slides get shown. So you all saw this, a team of pediatric cardiology, pediatric infectious disease, and primary care put their heads together to look at what testing, what return to play guidance there was in the literature, because the AAP came out with a statement about the risk of myocarditis or potential myocarditis for children who tested positive for COVID-19. And the AAP statement is really, really broad. And the American College of Cardiology had an actual policy statement back in the latter part of the summer, early fall, that we utilized basically in developing this piece of guidance. So you've seen this before. Bottom line is essentially looking for a child to be asymptomatic for a significant period of time, originally 14 days after having tested positive for COVID. And this algorithm in many ways really tries to help guide people through who needs an EKG, who doesn't really need an EKG. Obviously, obviously, if a child is hospitalized for MIS-C, we're going to get cardiology involved and we're going to go down that path. So this was really to try to help in the primary care space and also to emphasize to people that we still need to be mindful that even in kids who don't have a lot of symptoms or get hospitalized with COVID, they can have sequelae. So now, guess what? There's changes. So the ACC came out with a revision to this statement in October, it was October 26th, in which they changed the period of time that a person needed to be asymptomatic before they could re-engage and begin to participate in activities or play activities or sports again. It changed from 14 to 10 days. They also changed the year, the age range at which you need to think about EKG. And so as opposed to the last slide you saw, it was 12, now 15 is the cutoff. But then there's other things. So this is the question to ask you guys and to debate with you all and to get your opinion about. All of this stuff is being based on information that people are learning as we go, right? So none of this is something where we can say we know everything about this topic and we know exactly what child we need to do what with. There's a lot of questions about, should any child who's had COVID-19 have some form of assessment with their PCP, particularly the kids at age 15 and up, but even the younger ones. So there's a big debate that's going on right now. Should we just be stating that patients who have had COVID-19 infection are now being released from isolation at 10 days? Should they be referred back to their PCP for a brief cardiac assessment, both history and physical, and then determination if an EKG is indicated or cardiology referral, or if that patient can return to play. So I can tell you, I can talk to 7 different pediatricians, and 7 different pediatricians would have one of 2 opinions. We should see them all, or we should see only some of them. But I think that it's really hard to say, I think, to say a child's not having any symptoms if we're not asking what those symptoms might be. So the Return to Schools Task Force has come up with some ideas about this, and I would love your feedback. So this is tiny, I'm sorry, you might need to put your glasses on to take a look at this. This is a sample, just a draft of sort of a protocol and a release that we could use in these cases. So basically, obviously demographics at the top, when the date of onset of COVID symptoms and the date of the positive test, date of resolution of symptoms, and whether there was hospitalization or more severe symptoms, whether or not there's a history of cardiac abnormalities, which actually is a really important question in this case. And then really looking if there are any recent symptoms and really asking, inquiring about these things. Obviously the cardiac symptom checklist, whether or not there's a normal exam, and then obviously whether they're cleared or not, or whether EKG or a cardiology referral is indicated. So I'm going to stop sharing that for a second. And I'm going to just say, it's not clear from the guidance. If you read the AAP stuff, which is not a formal guideline, it's sort of like a little statement, a couple paragraphs in a statement, and then it was captured again in the AAP news. Their statement says every child who has had COVID-19 should have a cardiac assessment, a review. But it's not like an official AAP statement, but it's when the AAP puts something like that out, we're all like, is that what we need to do? That is not what is suggested with the ACC guidelines. So I really want to ask you what you think about that. Do you think you can, or first of all, if we instituted something like that, do you have the ability to see those kids in your practices, or are you too swamped? This would not be a traditional, this would not lend itself well to a televideo visit because you need a cardiac exam. And I can tell you that George Porter and Brenda Tassini and I all debated this yesterday, and I decided, so I'm just bringing it to you guys to get some feedback from you. So feel free to jump in there. Or I'll just call on you and ask your opinions.
Okay.
Yes. Hey, Toby.
I'm loving that we're talking about this because it's been like, it doesn't happen often, but when there's like one of those weird questions, you sit there and go, which way do I go? So my response would be, as long as somebody can do some preliminary questioning and discussing, if everybody's comfortable, we don't necessarily have to see the patient. But if there's any question mark, because there's so much that we don't know, my response would be, let me see the patient. After a set of vitals and a complete discussion, an EKG is really not tough to do. And if that can help us, reassure everybody, including ourselves, that's not a bad way to go.
And I think that the guidance really is pointing out that most kids will not actually need an EKG. I mean, your kids who have had more severe illness, but I mean, this question of when kids are being released from isolation right now, they're not being released after having done a checklist of cardiac symptoms. It's asymptomatic or no. So we could certainly also ask if the health department, as they're releasing from isolation, is able to do that. But I saw Mary Beth. So Mary Beth, you wrote on there, I'm trying to pull that back up again, that you would like to see every patient who has had COVID and feel uncomfortable clearing without seeing them.
Exactly.
That's how I feel, but I don't want to run with my opinion. Do you have the bandwidth to be able to do that? It's not that many kids, right?
It's not that many kids. It's not that long of a visit, but we have parents call up and ask to be cleared. They say, oh, there's no symptoms at all. He's fine. And then you get the kid in there and, they're having this pain or that pain. You just don't get a straight story unless they're sitting in front of you. And it's kind of big stakes. I don't want to send somebody back into sports and have them have a bad outcome because I was too busy to see them. I mean, that's a kid that needs to be seen. We will see those kids.
Anybody else want to piggyback? Thank you, Mary Beth, for that. Anybody else want to piggyback on that?
I would agree. I would agree.
Thanks, Toby.
I mean, I'm in a situation where I talk to my parents firsthand, and I'm in a different kind of scenario than a bunch of practices. So anybody that's got a question of a symptom, it's sent to me. So I talk to them directly and I ask poignant questions. And I know my patients, so I can tease out when they're just worried or when there might be a real issue. So I kind of have it easy in that way. But I agree, because so many times we hear different answers from different patients, from different people.
LJ,
This is Asante
There's some
from
in the chat.
Pediatrics,
Yes.
CMG Peds. I agree. I think we should just see the ones who see them all. I mean, it's going to be such a few number, and so many times you don't get an accurate statement over the phone. Plus, you get so busy in clinic rather than just counting on your staff to call the families and ask the right questions. You'll end up doing more work rather than just having them come in, for a checkup before they return.
That's great. That I appreciate that. And I'm reading Teresa Albert's comment in there. Again, same thing. They do want to see them, happy to follow these guidelines. They have the ability to see them and can do the EKG. So we do have assurance from Peds Cardiology. So this work has been done in close collaboration with George Porter and the whole Peds Cardiology team. And they have stated, particularly if it's indicated on the EKG that this is a patient with COVID-19 who requires that EKG for release based on your assessment, that they will turn that around in 48 hours. 24 is tough because, as you know, if the patient goes and gets the EKG done, it may not be read until the end of the next day, but within 48 hours, you should have a report. And George felt that that was reasonable and they would be accountable for that. So Corey just asked the question I was going to ask. So are we saying that for everyone over 15 who had COVID, regardless of 3-day or less symptoms? And that is my interpretation of what we are saying. My question for the group then is, do you feel like you need to see the children under 15? I'm going to go back to Mary Beth. What were you thinking when you gave your response, Mary Beth? Were you thinking 15 and older or all kids?
We want to see all kids who have had COVID. Some of the parents are worried about long-term symptoms. Some of the parents are way not too worried. We just want to touch base with any family that has had COVID. It's important that we realize where those kids are, how it affected their schooling, how the family's feeling, what the extended family is experiencing. Lots of times these kids come in, the kid had COVID, now the grandma has COVID. There's just a lot of layers. And we want to see those kids and check their health and check their mental health. And, there's a lot of anxiety with the diagnosis. So we're seeing everybody with COVID. I mean, if they want to come in, we're not forcing it, but we're really encouraging it.
Good, I'm seeing some agrees in the chat there. That's honestly, when you think about instituting some kind of a policy that makes sense to parents as well as to us, this is way more straightforward. This just makes more sense. And I think that the school health, the school physicians, the school health medical directors, the nurses, everyone will feel better about, because they're very worried about missing a kid who might just be kind of slipping back in. And I think the other thing to keep in mind is, even if it's not a young person who's doing sports at school, so many of these kids are still participating in club sports or other activities. It just makes sense. So you all didn't unanimously say that you wanted to go this route. So if anybody strongly disagrees, feel free to throw it in the chat or speak up. But otherwise, I think that we're going to go forward that way. We will share
LJ,
out.
did you
sorry.
see the comment about, did you see the comment from Dr. Stutzman about school nurses are asking for clearance for PE, not just sports?
Yeah. Well, and I think honestly, that is if you look at the AAP stuff, that is what they're saying. It's PE and sports. So we are deliberately leaving playground off of that because I think at some point that's just kind of crazy, but PE and sports, yeah. So Janet, the evidence behind this is what we're learning as we go. And you can look at, I can certainly make sure that some of the references are attached to this. There's even greater concern, I think, among like adult athletes, or certainly with college students. And that's where some of the guidance around the older adolescents is based. What age do we stop? I don't know what that means. Corey, can you explain that? What age do we stop doing the assessment?
Yeah, I guess you were probably answering it just as I was typing it. Like, in other words, okay, we know minimum 15 and up. Now we're saying every child who's had COVID is going to come in. We're going to examine them and check them out. But like even our older, so I know high schools, like I said, the high school nurses are looking for these notes. They don't want the kids in PE. They don't want the kids in anything, which was different than the guidelines that AHP published. So it was very confusing.
What? Right.
So then, but then at what age? So these college kids, they're all coming home positive. So we're going to see them as like just continue on, and for family practitioners, they should see then.
I can't comment on the adult space. So I would apologize for every family practitioner who's on here because I don't know the guidance there. If you have an athlete, if you have a college athlete, I would say absolutely those kids should be evaluated. But I would also check to see they may have already had evaluation at school, because most of the college programs, the trainers are doing that. And somebody's just posting something else in the chat. Man, I can't keep up with you guys. Uniform template, what age do we stop? Agreed. We are not going to do this, but I see the benefit. Okay, thanks, Sarah. Yeah, so Corey, I don't know. I would think it would have to be adults who are doing more, competitive activities, but we haven't put forth anything in that space, really looking in the PED space right now.
LJ, this is Carolyn. I'm going to disagree a little bit. There's plenty of these young kids have no symptoms. The families have no interest in coming in, and nobody's asking us to clear them. So given that the cardiology policy you just showed goes up to increase the age, I don't know how we're suddenly going to be pulling in every last kid who had COVID and they barely had symptoms. I mean, that doesn't make sense to me. So if we're trying to get a community consensus, I have some hesitations with that.
Carolyn, do you feel comfortable with the 15?
Yeah, I don't have a problem with that. You have a cardiology guideline, and when it said 12, I have no problem with that. But saying, an 8-year-old who had, barely a sniffle, they got tested because there was COVID in the house, they're positive, they're fine. The family has no interest in being seen again. I don't see what we're clearing them on. I understand that there may be various issues, but I think most of those patients, in my experience, are going to say no, they don't want to come in. So before making a guideline like that, I would have some hesitations. I don't have a problem with the 15 and above.
Okay. This is exactly where we came down to last night. I'm just going to say, because we are creating a guideline, right? We're not modeling someone else's guideline because there isn't another guideline to exactly follow, because the advice that's out there is pretty vague right now. So Carolyn, we'll take that piece under advisement, which is exactly some, information that's been shared by other providers who are very concerned that it will just create more pushback from parents. I would say that Claire's question about maybe the 15 and under could be a telemed follow-up. You may still run into some of the same problems. Families feel like that's not a necessity. Again, if you think about school sports, you're already looking at your older population, but obviously it goes into the middle school. So this is going to require a little bit more debate. We will try to put forth something that is smart and balanced and doable. I would say if the guidance that we put forth over the next couple of days is less restrictive, if it's 15 and up, requiring that. I think it's still, I think we will have some language in there about still the opportunity for our families to consult with their PCP for a child who has COVID if they have concerns. That would be the way I would handle that, so that people could still put into practice what feels right for them, for their patients. We can never legislate everything without a clear guidance. The list of symptoms that people need to be aware of and to call for, Toby, is really what's in that checklist. It's really cardiac symptoms. So that is something that we will put out, and maybe we can even put in just a separate messaging for you that you can share with your families. We will continue to work with the county health department too, to see if they could incorporate, this is my other hope, if they could maybe incorporate the question list into their release from isolation, then that would actually cover things better for those younger kids too. And would make me feel like we're doing more due diligence. So I don't have an answer for you guys tonight, but this is helpful information. Anybody want to dive in? Renee just gave me the 3-minute warning. She's going to give me the hook in a minute. Anybody have anything else they want to add to that conversation? Okay, man, we're rolling here tonight, you guys. Okay, so the next part of our talk tonight is really, I think, an opportunity to talk about behavioral health. And Mary Beth gave us a nice lead in to that, thinking about just the amount of anxiety, depression, uncertainty and distress and isolation that all of our kids and families are going through. I wanted to leave some nice open space for you all to talk about what you're seeing, for Holly Brown and for our care managers to talk a little bit about some of the depression screening work and approaches, strategies that are happening. But this is, Holly, I don't know if you have any formal things you want to say in this space, that I can turn it right over to you, or I wonder if you want to have the group just talk a little bit about what they're seeing to start off.
I'd be eager to hear from the group, LJ, see what folks are seeing.
So if you're willing to unmute, it would be really helpful, especially as rates are rising and people are more anxious and worried, and we're seeing so many more people going into the hospitals. What's happening for you guys? What's happening for your kids out there?
LJ
Yes, Liz.
Walsh. Okay. So I have to say that I've been struggling with feeling like a fraud as a pediatrician right now, because my own kids are struggling so much with this whole thing. And when parents come to me asking, well, what can I do? And it's like, what is there to do, really, in a lot of ways? And so, I think that's been part of what's really difficult, is that all of the stuff that we've learned over time as coping strategies and things that folks should be doing, a lot of that doesn't feel like it relates in this situation. And so it just gets harder to come up with ideas for people, is really what it comes down to.
Mm-hmm. I appreciate what you said there, Liz.
It's a brave admission.
Mm-hmm. I'm right there with you. Anybody else want to share?
Yeah, this is Corey Wart from Brighton Peds. I just wanted to say that I feel like the acuity is changing. Like in the beginning, there were a lot more kids with anxiety, kids who had never had, but now I'm starting to see a lot more cutters, overdoses, referrals to CPAP. Like it's escalating, and access to care is a huge issue. And so I feel like there's more safety and more critical issues starting to stack up. And I spend more of my time in mental health than I do in the practice of general peds right now, I feel.
Okay. Does that resonate with others? I see Gail's head nodding. And Toby
Toby
says
Hi.
yes.
Yeah, from a rural area, I'm actually finding parents getting also more irritable, understandably. Like sometimes I think the kids have more resiliency, but I'm hitting a lot of parents just angry about mask wearing in the office, which we've been doing forever, but you know, families storming out when asked to wear masks. So there just seems to be, everybody's at their tipping point. And, you know, we're a small rural town. We have not been hit hard by any sense, but, you know, the parents are struggling, to me, more than I'm seeing the kids, although I am getting a number of kids that seem suicidal and are having issues. But boy, the parents are taking a lot of my energy.
I saw a question in the chat. Thank you, Gail, for sharing that. I saw a question in the chat about, you know, just trying to find therapists for people. And is there any general number to call? I can tell you that there's a lot of work we're trying to do right now to try to update resource lists. I give a lot of credit to Strong Behavioral Health and the teams there who've done a lot and our care managers who do a lot to try to update regularly lists to find out who's available, or sort of phone a friend to see if they might take one more person. And we're trying to actually formalize a process, like have something like that continues, you know, hopefully beyond the pandemic, but, you know, over these next months, where we can have updated lists. I will have to say, on our website, you know, one thing we might want to do, I'm thinking, is maybe we could call out the behavioral health resources again and make sure we have the latest version of updates, and we can put that, you know, sort of front and center again on the website. And I think that that's the thing, is getting connected to, you know, what you want to do is you want to get kids connected to someone that they can talk with and who has the skill set to help them before they need, you know, CPAP or mobile crisis. Holly, what thoughts do you have, or comments do you have for the group?
One of the things that I was wondering about, I know Emma, I don't know if Emma's on, but she was working with a group at Strong around resource organization. And Emma, if you're on and you want to shout that out, that would be awesome.
Yeah. Like, it was through Strong. I'm trying to remember offhand.
You were working with the behavioral health group, the resource management group.
I think Holly's referring to the group that you were on, that I was helping to lead, right?
Oh,
Yeah.
okay.
Yeah.
I mean, we haven't met in a little while, truthfully. I think from all care managers, I won't speak for everybody on the call, but we are kind of trying to do our best. I think with getting as many updated clinicians, like LJ is kind of noting, the challenge, of course, has been, you know, we'll call one day. I've had some parents that I say, oh goodness, please call today. You know, they said they're open and they have some spots. And within the next day or two, it's full again. And then we're having such varied times that I think Strong, I will say Catholic Family Centers, Genesee Mental Health, Villa of Hope, they've really been very flexible with, I think, care managers kind of, you know, working with their organization, saying, look, this is a kiddo that's really having some difficulties. And I will say the child and adolescent partial program, I know those wait times are significant, but I think it's Carolyn over there who takes the intake now, has been doing a really wonderful job working with our offices to say, you know, hey, if you do have a priority, please let us know, because we can really try to make sure that kiddo gets in or gets seen. But I've been really impressed by the community clinics and how they've been stepping up. Even with the wait times, they've been really accommodating to some of our outreach for some of those really challenging cases. And I think we've been seeing, like many PCPs and everybody's echoing here, a lot more of the mental health sector that's really coming up. And I agree in terms of the parents wise, that's been a challenge too. Parents are feeling extremely overwhelmed that this is continuing. And I think the fear of the school changes and whatnot, I know LJ obviously spoke about, you know, that being secure to some extent. But I know parents are really having some troubles. I think continuing to balance this, especially with the holidays coming up. And Holly, I don't know if that really answered your question.
Yeah.
Okay.
Yeah. So a couple of things that stand out to me in terms of what folks are talking about is, I think the social determinant issues are persistent and increasing. I heard in my own practice today more concerns about food insecurity than I've heard in quite some time. And I think just the general uncertainty of things is wearing on folks. The two sort of pluses in the last 48 hours certainly are around the hope related to a vaccine, and that could be a reality for us soon. And I think it's a big step that around keeping schools open. These kids are thirsty to be in school, believe it or not. I work in day treatment programs outside of AHP, and these kids are really bummed that they're currently remote. And it's surprising to all of us that they just want to be in a structured setting, not so much to get away from home or any of those things that you might think about, but just to be face-to-face with people, having that interaction, and really sort of having something more normal. So I do think those things are real. Thank you for calling out the BHI resources, LJ. And we should refresh those and make sure that they are front and center for folks, because there is certainly resource phone numbers to get folks connected, as well as the depression toolkit for you to refer to around if you're needing to get something going. Please don't forget that we do have our Tuesday 12:15 BHI calls. We talk about everything from soup to nuts. If folks have been on there with some regularity in terms of diagnosis and treatment, as well as resources there. And that can be a rich discussion that I think has a really good ripple effect. Our depression, universal depression screening is initiative is alive and well. We are happy to find a time to meet with you all over Zoom, because I don't think that you'll want us to come to your office, but I'm happy to meet with you, find a time to meet with you to talk about the initiative, to walk you through the toolkit. And, Elizabeth is snazzy with all of the technology, the technical end of things. So Elizabeth, do you want to say anything about the quality measure related to depression?
Just that we are looking at continuing to work on that in 2021. I know that Willie Newdigat, who's I believe on the line, has been doing some work with individual practices for data validation. And so, we'll be reaching out as folks have time. I know you guys have a lot of other things on your mind, but if this is something that you have the bandwidth and desire to work on, please let us know. And we'll be following up as well, because we want to make sure everybody is comfortable with what they're doing, and that you're getting credit for the work that you're doing.
Yeah. The other thing to keep in mind, I think, is Emma said, and I think that probably be all that for me, LJ. The community resources are pretty are more robust than they have been from the standpoint of crisis support. So someone mentioned, Dr. Wirt, you talked about individuals who are engaging in self-injurious behavior or those sorts of things. There are community services. I know Hillside Children's Center, you can call the service integration number 585-256-7500. They have what's called Kafka's services, which are more enriched crisis resources. They're not plentiful. Not everybody's going to get a crisis worker, of course, in a timely manner. There are limits there, but they are much more available, more flexible, meeting folks in their community and doing some of that brief crisis intervention work. So as a way to manage those resources. So I think that's what I have for tonight, LJ.
Thanks, Holly. I appreciate that. Holly, do you mind putting that number into the chat? Oh yeah, you're awesome. Good. Sarah, she'll take care of you there. I saw Sarah's question. I'm sure other people were trying to write that down really fast. I wanted to talk about another opportunity in terms of, behavioral health partnership. And, when we talk about looking for therapists in the community, we also have, and among many of the schools, behavioral health resources within the schools. And so we've had this conversation over the last year, talking about how could we begin to build better bridges between our schools, our behavioral health providers that are in schools and within the community and within our practices, and then with our practices themselves. And so there's been a lot of work leading up to the pandemic, a lot of accelerated work during the pandemic to try to bring that to reality. And it always seems like just when you're ready to do something, there's something else that gets in the way. So clearly, for all of you, the timing to launch something like this and begin some of these dialogues was not when you had to test everybody in the world who had the mildest of symptoms. So we knew that wasn't quite the right time. And then the right time was not when the schools all had to start testing kids and coming up with this new format. But you know what? Behavioral health is critical, and the concerns are there whether the kids are remote, whether they're in person, whether they're, whether they're in the city, the suburbs, or in rural settings. And so Allison Stiles has joined us now. Thank you, Allison, for coming on board. Allison is a postdoc fellow with the University of Rochester psychology program in pediatrics, and has been working closely with Melissa Heatley. Many of you know Melissa. And I'm going to actually share my screen, but then Allison, I'm going to let you talk about these bridging opportunities and what the first one looks like. It may be on the west side of town. So you feel free to start talking, but I'm going to share my screen and just put up that sort of invitation to connect for kids. Sorry, it's going to take me a second.
Thanks.
We're still back on old news. There we go.
Great, thanks, LJ. While you're looking that up, really good to meet everybody, and excited to talk a little bit about this opportunity. So as LJ was saying, this really, came about, it has been going on for a while, but came about in the wake of COVID-19. And definitely, as I'm hearing all of you talking, it's a time when we really need to think about how can we find other ways and to really support kids' behavioral health. And so this initiative is really a product of some of the work groups that have been going on to think about how to do just that. So this project, the Connect for Kids, is a 2-hour guided conversation to really facilitate between pediatricians and school teams. How do we best support kids' behavioral health? And so how do we create and think about a shared vision between these two really important systems in kids' lives? How do we understand, what's already being done in each of these systems to address behavioral health and really capitalize on the strengths of those two systems? The point of the conversation is also to really start to get at what are we already doing to communicate well and collaborate well across these systems, and also what are the barriers that have been coming up that make it challenging to really be able to connect, especially when everyone right now is so swamped with just trying to get by day to day. So how do we think about how to have really easy and clear ways to collaborate and communicate across these two systems? One of the goals too is to think about coming out of this conversation, how do we have some clear action steps? And then when it's appropriate, with a lot of schools, we're going to be thinking about how do we have a follow-up conversation between schools and primary care offices to think about after that initial 2-hour conversation, how's the follow-through going and where are gaps and where are barriers coming up? Especially during this time with closures and social distancing and all the things that are really impacting our families. The other piece too that comes from this conversation is a lot of folks have spent a lot of time creating this Connecting for Kids COVID-19 practice guide. And so within this practice guide are best practices around how do we support kids and how do we collaborate during this time related to behavioral health in particular. And so, we are starting to pilot these work groups, or these evenings, which is really exciting. And we're hoping to kind of really start to get things off the ground so that we can, make some good movement. And LJ, I know that you were a part of a lot of that and the initial work with kind of creating and developing the Connect for Kids work. And I wonder if you want to add anything to that.
I think you did a great job explaining it. I think it's just, when we think about what we can do better, always we can communicate better, we can collaborate better. And when we do that, it really does fill in some of those gaps. And I know that for the schools, they are identifying, when I sit in meetings with school administrators and teachers and nurses and therapists, they are all just saying it's the social, emotional, behavioral health concerns that are the greatest thing, are the greatest concern. And they're equally as worried about, maybe even more worried about the kids they're not seeing, the kids who are remote, than the ones that they're actually getting a chance to even see at times. So they have exactly the conversation we're having here about what you're seeing in your practice. Corey saying that, she's spending more time on behavioral health than traditional physical medicine. They're seeing the same thing. They're trying to focus on education, but they're concerned about behavioral health. So I feel like this is our chance to begin to develop those partnerships. And for many of you, I know when I was in practice, I had great relationships with certain people at certain schools. Like they were my go-to. I could pick up the phone, I could call them if I was worried about a kid, but I didn't have that with all kids. I didn't have that with all of the schools, and none of us can have it with all the schools. But if we formalize some of these relationships with the schools that are sort of in the catchment area where our patients are coming from, it's a first step. And it will help any other provider, pediatrician, family physician, nurse practitioner who is trying to make a connection for a child if some of those things are formalized. So as a launch to this, there's two places where this is going to start right off the bat. The Greece School District is very interested and has asked to participate. And so Melissa and Allison are looking for providers from practices who are seeing kids predominantly from the Greece School District, or who see a number of kids from the Greece School District who would be interested in participating in a conversation in January. The request for the practices would be to identify at least one clinician or more who would come to from our team. Your care manager will be involved in that. And that, can you guys hear me okay? Because my internet apparently is unstable now. I hope I don't. Okay, good. I hate when those things start flashing. And that you would include an administrator from your practice as well. So we could think about some of those things. What are the barriers to communication? How can we facilitate these things better? So for those of you who do have patients are located in the West Side, if you would be willing, if you're welcome to volunteer in the chat, we will be sending you an actual more formal invitation to ask if you're interested and willing to participate in that first conversation. The other place where this is going to start is actually with Rochester City School District. So for those of you who are not aware, there's been tremendous movement on the part of not only the leadership, but even the teachers union, as a result of many conversations about the importance of trying to get children back into Rochester City School District for in-person learning, for those whose parents are willing for that to happen for them. And so in addition to bringing back the children with special needs and requiring special education and modifications in the first of the year, in February, they will begin bringing back the pre-K through elementary age children, and then moving from there to the middle school children, and then on in anticipation is by late February for the high school students. So I think the opportunity to have conversations with our CSD, it's going to look a little different. Every school is different within the school district. And so they're looking to identify some of the buildings where the administrators are most interested in working on this issue and then build out from there. So I know many of you care for kids in RCSD, and so we will be looking to see if you're willing to participate in some of those conversations. And there's a lot of opportunity to participate in other community conversations. For those of you who are willing, please let me know. Many of you have reached out with different offers for volunteering for certain things or being willing to participate. There's a lot of listening conversations that need to happen right now with families across our region, listening about their fear about COVID vaccination, listening to their fears about flu vaccine for that matter, and being able to really dialogue around that and just talking about what this means. So stay tuned. You'll get more invitations for that kind of thing as well. Thanks, Allison, for joining us for that piece.
Absolutely. Thanks, everyone.
We will move this out to other school districts too. So I would just say if there's a practice who's really anxious to get started doing this in their area and they need help facilitating connection to a school, it can go both ways. That we've initially been reaching out to the schools, but please let me know if you'd really like to help drive that in the schools that are in your area, whether that's within Monroe County or outside of Monroe County. We would like to help facilitate that too. Last thing, oh no, looks like there's things in the chat. Is it Renee telling my time is almost up?
It is.
I was just about to say, I know I need to move on. I'm going to do it before Renee tells me to, but thank you, Renee. So guys, we're totally going to shift gears here now. And I want to tell you about a really exciting opportunity for you and your practices that will be coming up in 2021. And I wanted to be able to tell you about it here so you kind of hear it first. You can answer more questions about it over time. And let me just change my, oh boy, technical difficulties are abounding. Hold on. So for some reason, oh dear, I cannot show my, there we go. I'm just gonna do it this way. Sorry, see on the slides on the side. I want to talk to you about universal newborn home visitation. And I want you to just love this slide. Just love this slide for a minute and tell me what you see. I want you to see it's one of the first anti-maskers, the youngest anti-masker. See that little baby just grabbing that mask and pulling it off of that doc's face. I love, or maybe it's a dad's face. I think it's a doc's face. Anyway, I love that picture of that baby. So think about the pandemic. You all know this, right? Babies are getting discharged even earlier from the hospital. We're back to that again. 26 days, or 26 hours. We're asking to be the lower limit. Families are going home again to more isolation from their own families, from their resources. We're right back where we were, if not even worse, actually in March. And back in March, we talked about the fact that we had a plan in our community to bring a universal newborn home visitation model, an evidence-based model here that would allow every baby and every family to have at least one home visit from an RN. It's a great model, comes out of Duke, North Carolina. It's got great evidence behind it that it has a real impact on all families. So there's no stigma attached. Doesn't matter what insurance you have. Doesn't matter if it's your first or your seventh child. So we've been planning to do that, and we were poised to begin actually implementing, and then the pandemic hit. And so it was not a time to do in-person newborn home visits. And it was not a time to stand up something with a nurse home visitation centralized program. And so I just want to give you a little background on this. And then I want you to tell you what we've got going. So in this space, we had secured funding from the United Way and ESL to bring this model that's called Family Connects to Rochester. And so, as I said, we realized it was kind of time to do whatever innovation we possibly could in this space. And so I want to talk to you about what Family Connects is and what modifications we are making now to this to be able to actually launch this. So Family Connects, as I said, it has 2 randomized controlled trials that basically show a number of different outcomes, including reduced postpartum anxiety and depression, more positive parenting behaviors, improved home environments and increased community connections for families. It's an RN in-home visitation centralized model. That's what the Fidelity model is. Usually 1 to 3 visits from the RN starting at about 3 weeks of age. And, you know, in addition to all the positive outcomes of this model actually showed a significant reduction in cost and savings based on ED use, reduction in ED use during the infant's first year of life. So that was the model we were looking at. So what we are doing and are able to launch now because of support, both from the United Way, as well as from all of the different hospital systems and from our insurers, is that we're launching a Rock Family Teleconnects model. And this is really modeled after Family Connects International, but it would be televideo visits or telephonic if televideo is not available. And what the modification we're making to this is that these RN visits can occur out of the newborn's medical home, out of your practices. And the reason why we felt this was so important is that there are already targeted home visitation models. You know about these: nurse-family partnership, baby love, building healthy children, parents as teachers, that do great work. They're targeted home visitation models, right? They're used if there's identified needs, if it's a first-time single parent family, particularly if there's an adolescent mom. Those sorts of things stand on their own. They're really critical and important. But the thing is, if we stand up another model that has that operates outside of primary care, outside of the medical home, it's one more thing that's disconnected from the work that you do in your practice. And so as we looked at their model, you know, looking at it as a pediatrician, I was like, man, this is just like taking the well child model that we have and really amping it up in a way that's a little more personal, takes a little more time, has an opportunity to really see a family in their own home environment, and the opportunity to do more screening so that you can really get at some of the detail that's hard to get at when you're trying to do so many things in those early practice visits. So this week of life, so that we really can do some more intensive work around breastfeeding, and also really early assessment of emerging social determinants needs or anxiety or isolation, assessment of safety in the home. And basically we're using the same Family Connect screeners and script, but we've done some enhancements, as I mentioned, on breastfeeding support. We're really looking at trying to do a little bit of counseling on postpartum reproductive life planning, essentially postpartum LARC, making sure moms know that's available to them. Looking at tobacco relapse for the mom and assessment of prenatal supports. So if a family was already connected to nurse family partnership, is already involved, your practice would know about that right away, because it would be a nurse from your practice who's doing this visit and who is getting the opportunity to collect that information. So connecting the dots. We have set this up so that there would be direct consultation support from our care management team, a select group of our care management specialists, the two women who are RN care managers in the women's health practice, and so who really know all of this work around maternal depression, tobacco cessation, and postpartum LARC. And then working with Katie Whiteman for all of her amazing expertise and ideas around lactation support in the early newborn period. And then also Nikki Spring, who some of you may not know, but Nikki worked with Baby Love for a long time. So nobody knows community resources and home visitation probably better on our team than Nikki does. And then Nancy Bellish, who in her RN care management role is actually starting to pilot these to see how this all works, to work through the kinks. And I thank Joanne Cordero and her practice, and Joanne for willing to be a partner in that very first pilot with these visits. So what does this actually really mean for you guys? Sorry, I will show you what it means for you guys in a second, but this is just basically the goals. You can see it's the quadruple aim, right? Improving health outcomes for moms and babies, reducing unnecessary ED use and cost for babies, improving patient experience for the mom and family, and increased satisfaction for our primary care practices caring for the newborns. So the people who've been involved in this piece I wanted to call out the United Way, and I wanted to explain to you guys that this is not just happening within AHP. We are really launching this initiative across the whole community. Rochester Regional is doing this in their practices. Anthony Jordan Health Center is doing it within their practice. Golisano Children's Hospital's pediatric practice will be engaged in this. And then we have the opportunity to do this through AHP as well with our independent practices. New York State is really excited about the work that we're doing, and they have now named us as a pilot in the first 1,000 days. So we will be seeing some additional dollars and resources coming to our community in the spring. So not yet, but in the spring, that may actually help us build exactly some of the things we were talking about earlier, like a really well coordinated resource hub for information on whether it's social determinants needs for referral, whether it's behavioral health needs, and some actual navigation for that, as well as some good stuff for a data platform for integration. And then I just have to call out, we've got insurer partners, and I did not come to any of you about this project until we were sure that we actually would see reimbursement, because I knew that it was impossible for any of our practices to do more without getting compensation for that work. So Excellus was the first partner to step up in this. They've been working with us for about the past 3 months to 4 months on what this would look like. And they have agreed to provide a specific code with billing reimbursement that's commensurate with the level of service that would happen in this video and this televideo visit. So if you think about it, this would mean 1 nurse from your practice, maybe 2, depends on the size of your practice, participating and training with us. And then in that first week of life, depending on when you do your first visits, so this can be tailored a little bit to how your practice does your in-person visits, they would conduct an initial call following the sort of screening protocol and the conversation script. Reimbursement for that visit will probably last between 45 minutes to an hour max. And the initial compensation for that initial visit on commercial would be $140 for that visit, $125 on managed care. And Excellus has agreed to 3 follow-up visits, recognizing we're seeing already with the visits that have been launched from Rochester Regional, about 90% of them are needing follow-up because they're needing referral and connection to other resources. And so the follow-up visits, which would be shorter, will still be reimbursed at rates of 93 on commercial and 83 on managed care. So it's a lot more than what your typical RN televideo visit would be in this. The specifics of how they're going to do this, rather than running up against what we've run up against during the pandemic all the time, which is Excellus agrees, or any of the insurers agree to a particular code and a billing thing, and then the actual people that you work with from Excellus say, oh no, we're not going to compensate for that because it hasn't come out in writing yet, it hasn't made it to us. Excellus will actually do an addendum to your contract. So it will be an individual addendum to the practice contract that will state, we will reimburse you for this service at this rate. Everything will be in writing. So anyone who signs up and decides to participate in this, any practice who does, will have assurance. They will have it in writing. It will be a contract addendum that they can hold in their hand and have ready. The agreement we have with Excellus right now is a full 1-year commitment to do this work with anticipation of continuing. They are super excited about this. And they're willing for us to do a rolling enrollment with practices and no limit on the number of practices who we engage with. So for some of you listening to me talk, if you're thinking like, wow, it sounds like a great idea, there's no way and heck we could do that in January, it's okay. You know, if February or March is a better time to begin for your practice, we can do that. But as more of you are moving to televideo visits for your patients, I know what was happening before, earlier in the pandemic, you were trying to figure out what your nurses might be doing if you're not seeing as many in-person visits in the office. So this may be something, this would be a great way for one of your RNs to contribute. And I think it would be, you know, really them getting a chance to learn more in this space from our team, and would also give them an opportunity to, you know, work to the level of their license. Many of our RNs are amazing educators, and they really enjoy connecting with families. So The resources we are promising in this, you know, like I said, our AHP team is piloting these visits this month because we're going to work through a lot of the kinks. We've got training videos from Family Connects International and additional ones that our team has done and are completed. There's a whole screening script that right now I'm going to be looking to get some help, and I can't see her on here right now, but Liz Walsh, you're in my head and in my heart right now, because we could really use some help taking this screening script and translating it to an EMR document template that could be used in MedEnt and then in other EMRs as well. If you're interested and willing to help in that space. We will do coding and billing support for the practices in terms of just making sure your billing office, I would tell you this is very straightforward. It is a code and the reimbursement is very clear on the contract. I've seen the draft contract agreements. It's not complicated. And then we are developing a toolkit with resources so that as nurses are identifying issues, there will be a number of things they'll be able to do referral right in the moment because they'll have those resources, or be able to call a family back with those resources. And our AHP care management team, particularly this core group that's worked on this initiative with us, will be available for questions. So we're going to be seeking interested practices starting in January 2021. And this will be, like I said, rolling out throughout the winter and into the spring. We do not need everybody enrolling right in January, but it'll be really interesting to hear what your interest might be in this. There would be a training commitment. This is not the idea that you have to actually train in this model in order to bill for these visits. It can't just be a call from a nurse to check in to see how a patient is doing after the baby's born. This really has to follow this model for it to be reimbursable and to be effective. But there will be some participation requirement on the part of the RN to do a monthly 1-hour Zoom with our implementation team, just to make sure, you know, for them to ask questions, give feedback. We obviously are available to them at all times for questions. And right now, I have to say, for those of you who are outside of Monroe County, I apologize, but right now the focus for this phase 1 implementation is in Monroe County. But the idea for this would be to expand this out further, certainly as soon as we can. But Excellus, and I have to add the MVP has just signed on, and they are willing to compensate as well. So it's not every patient, I recognize that doesn't capture every insurer, every insurance, but we're really trying to pilot this. So a focus on those patients in Excellus and MVP, I think, is okay for a first year of trying to lift this off the ground. There are 8,000 births a year in Monroe County. Our hope is that working across these systems, we might hit 2,000 by the end of the first year of implementing this. That would be our goal. So I'm going to stop talking. There were a bunch of questions that were showing up in the chat, and I have no idea what they were. So Renee, is there ones I should definitely address? Yes.
Sure. Is Excellus applying this fee to a family's deductible if the family has a health savings account, or covering universally like a well child exam?
Universally like a well child exam. So we, you know, this is why it's taken us 3 months to get to this point, because we've gone back and forth on things, and there can be no cost share. So one of the things Excellus is doing right now, if you think about the self-insured plans, who sometimes state that there has to be cost share, they are going to have to specifically sign off that there's no cost share on this. So they are actually working with all of their self-insured plans right now to get them to sign off on that as well. There cannot be cost share on this. Great question.
The rest are comments. I love the idea of new training and responsibility for our nurses. They'd love to expand their skills and would be great at this. Oh, I'm sorry, I need to go back to Dr. Dovicki's question. Also, to clarify, RN only?
Yes, it is RN only. It cannot be an LPN. I'm sorry about that. We have to have some fidelity to this model. It's RN only, and we're recommending it be RN and not NP. I mean, really, this visit really should be an RN that's doing it.
Westside and Pathway are in, and Dr. Dovicki says, sounds amazing, but also sounds like a full-time job position for an RN, lots of babies. Are there RNs out there for hire?
It's a great question.
If you find any, let us know.
Yeah, I think a lot of people are looking for RNs right now. I think in a pilot year, it's not a full-time position for an RN, right? If we're trying to pilot it, see how it works. We're not trying to get every single baby. It'd be nice to get every single baby, but we're not trying to get every single one, just trying to get that process established, that knowledge base. I think we'll have to see where we go with that. But we were not envisioning this would be a full-time job for one of the nurses in your practice. We would love to just train them up and have them be able to do at least some of these. Other questions?
Panorama is very interested.
Sweet. Okay. Thanks, guys. Thank you for being excited about this. We are like, we like the care management team, Daryl, who's been working on this with us. The other systems, I mean, one of the most enjoyable things about this has been sitting and working with amazing people at Rochester Regional and at Jordan and at GCH Peds, and knowing that you guys all, like our independent community practitioners, can be a part of this. It's been one of the joyful things out of the pandemic in the midst of all this other stuff. So I think it's really going to be great for families. So with that, I'm just gonna open the floor for the last 3 minutes. Anybody else who wants to say anything? I know Dr. Brophy's on. I don't know if he would like to say something. Elizabeth, I wondered if you would like to make a comment, just a quick comment about AHP's Equity Council, and then we'll call it a night.
Sure. So we wanted to let folks know that AHP has formed an equity council, sort of in response to the concept of racism as a healthcare crisis. We're working on developing our body of work, but know that we want to focus both internally at AHP and externally in the network to make an impact on patient care. So you will definitely be hearing more about this as we move into 2021. But we wanted to let you know this is an issue we find really important. We're very excited to work on. And personally, for me, one way we plan on doing this in optimization is, validating our race data in Arcadia and identifying quality measures with large inequities to see if we can address those moving forward.
Thanks, Elizabeth. And we will keep you all posted on that work. Thanks for all the messages coming in the chat. Pat, I'm going to give you last word.
Okay. Well, first of all, I want to say thanks for everybody meeting. I mean, this is a great meeting, actually. I think it brought out a lot of things. And what I also heard through this is that obviously there's a lot of stress within the provider community, within our group. And so I think that this is a really important forum to try and support one another. The fact that we're able to actually pursue something that I consider groundbreaking in the middle of a pandemic, and we will be successful because we have a great track record for it. I think that actually gives us a high note to think about, the future, because we are going to get through the pandemic, and we're all here to support one another as we go through it. And so I think that behavioral health issues also apply to us. So anyways, I just want to say thanks, everybody, and I hope you have a wonderful holiday season, and hopefully we'll get this pandemic under control, and then the sky's the limit, I think, after that.
I love that. All right, that's a perfect note to end on. Renee, even before you could tell me that we're done, we're done. How is that? You should be the timekeeper all the time. That was like, it made me stay on. You guys have a wonderful evening. Thank you so much. We meet again together in March, but I'm sure we'll be seeing each other plenty of times before then by Zoom. Take care, everybody.
Everybody.
Good night.